So this is chapter 29, care of patients with disorders of the lower GI system. So irritable, irritable bowel syndrome is also referred to as spastic colon or spastic colitis. Um, it's marked by chronic symptoms um, of abdominal pain. There's alternating constipation and diarrhea, excessive flatulence, which is gas. The patient might have a sense of incomplete evacuation of the stools. They might have abdominal distension as well. Irritable bowel syndrome, you might also see it as IBS, is a common stress-related disorder as well. About 20% of patients actually never seek medical attention because it is a benign, condition and no anatomic abnormalities or inflammatory components to it. It is twice as common in women as it is in men, though. So the cause of IBS, not known fully, but it can be associated with psychological stress, but it can also be related to some physical factors as well. You might actually have a familial predisposition to irritable bowel syndrome. It can also be caused by ingesting irritants such as coffee or caffeine, related type products. Raw fruits or vegetables can also be a cause. Lactose intolerance might be a cause. Abuse of laxatives might be a cause, or even hormonal changes such as menstruation might be a cause of irritable bowel syndrome. All right, so signs and symptoms of irritable bowel syndrome. You might have alternation from constipation or diarrhea or both. You could have, a combination of both or, either or. You might have some lower abdominal pain, which is usually relieved um, when you defecate or maybe when you pass gas or something like that. It might be relieved. Um, you might have mucorrhea, which is mucus in the stools as well. Um, Possible dyspepsia. What did we say that was? Heartburn might be another indicator. Abdominal distension um, might be another symptoms that you might see. So for treatment and nursing management for diarrhea and constipation, you want to tell the patient to avoid irritating foods and probably encourage them to develop regular bowel habits. So when we talk about irritating foods, you want to have them avoid foods that cause gas. So the legumes and the cabbage, things like that. You want to tell them to avoid things like the onions and potatoes, cucumbers, coffee, tea, um, carbonated drinks, alcohol. All those are, like stimulants, and they increase the gastric secretions. You want to restrict milk if they're intolerant to milk. Um, Teach them to keep a food diary to identify foods that might be irritating to them. Help the patient deal with stress. Teach them how to deal with stress and coping mechanisms. Warn them against being dependent on sedatives or antispasmodics or laxatives. Don't want to get dependent on laxatives as well. You want to encourage the patient to increase their fiber intake, drink plenty of fluids. That will help promote regular stools. Maybe they need stool softeners. You know, if constipation is the issue. Like I said, high fiber diets helps to maintain good bowels. Sometimes they need, you know, if they are having diarrhea, anti-diarrheals or bulk forming laxatives, like the Metamucil or something. Now, if they are taking those bulk forming laxatives, or you know, you want to make sure they're drinking plenty of water with that, because it will cause you to be constipated if you're taking all those things and taking, you know, those bulk forming laxatives and not drinking plenty of water. Maybe they need, you know, antidepressants, or, you know, whatever, you know, what's causing the stress. Or if they are having pain with these issues, they might need some type of mild analgesic or something like that. Wear loose clothing if the patient has bloating or whatnot. And if stress can't get under control, then maybe they could benefit from some type of cognitive therapy or psychosocial therapy, or even hypnotherapy if necessary. All right, so when we're talking about diverticular disease, you have sacs or pouches that can develop in a weakened intestinal wall. And so they're most common, and so this is called diverticula. The diverticula is the actual sac or pouch. They typically tend to occur in the sigmoid colon, but I mean, really, they can occur anywhere, develop anywhere, you know, along the colon, but it's more so in the sigmoid colon. So when we have diverticular disease, it manifests itself in one of two ways. You have diverticulosis, is when you actually have the diverticula present. They're present, but you're not having any symptoms or issues from it. The diverticula, the sacs are present, but you're not having any signs or symptoms from it. Diverticulitis. Diverticulitis is when you have the diverticula and they become inflamed. So when they become inflamed, then they can cause, you know, some type of fatal obstruction or infection or hemorrhage or something like that. So what happens is with diverticulitis, you have undigested food and bacteria, you know, mixed in that diverticular sac, and so that produces, you know, the inflammation, and if it's not treated, you know, can lead to infection, or, like I said, this fatal obstruction that can occur. Most of the people with this situation, it occurs in individuals that might be older. Most of the people tend to be older. The older you get, the more at-risk individuals might be with this, to acquire this. So in diverticulosis, the patient might not have any symptoms. You know, remember we said that you know, you have the presence of diverticula, but you might not have any symptoms in diverticulosis. These individuals could actually also have issues, you know, with constipation or diarrhea. Sometimes they might have left lower abdominal quadrant pain, but it usually goes away, you know, when they defecate or pass gas or something like that, you know, so it wouldn't be too bad. And when we talk about this left lower abdominal quadrant pain, remember we said it occurs mostly in the sigmoid colon, so that's why you might see the pain there. But remember, it can occur anywhere, you know, in that colon. That's just where it's most likely to occur, is in that sigmoid colon. So when we get to diverticulitis, these individuals are likely to have diarrhea or constipation, some moderate pain in that left lower abdominal quadrant as well. They might have some nausea and vomiting, bloating or gas as well could be an issue for these individuals. They could even have a low-grade fever, depending on what's going on. If the diverticuli actually rupture, a complication could be, that diverticula actually rupturing from the intestinal obstruction, and then you're at risk for peritonitis, and we'll talk about peritonitis here shortly. So when we talk about treatment and nursing management of diverticular diseases, it actually depends on what stage the patient might be in. So if we're talking about diverticulosis and they have no symptoms at all, then probably they wouldn't require any treatments of any sorts or anything like that. Diverticulosis that has some mild pain, like I said, sometimes it's relieved if they defecate or pass gas or things like that. So we want to do things that are going to prevent constipation. So high fiber diets, increase in their fluids. They might be taking bulk laxatives or stool softeners or things like that. So we're going to be doing things that are going to, promote bowel elimination to keep things flowing so that they don't get constipated. Now, if the treatment, if they have mild diverticulitis, and there's no perforation or anything like that, again, we're still going to be doing things to prevent constipation. So, all those things that we talked about before to prevent constipation, we're going to do those things. They might need some bed rest. They might need a liquid diet or stool softeners. They might even need an antibiotic as well. If they're having, some pain, they might need some type of pain medication to help control the pain as well, or an antispasmodic or something like that to help relieve the pain. Like I said, liquid diet, they might need a clear liquid diet for 2-3 days or so, while they're taking the antibiotics, and then they can gradually advance their diet as tolerated as they're able to. If they're having diarrhea, they might need antidiarrheals. Obviously, we're going to reinforce education with their diet and fluid intake and exercise or whatnot. Now, if it's a little bit more severe, if it's a little more severe and it's not, they can't control it, it's not responsive to medical treatments and things like that, these individuals may need a temporary colostomy so that they can, if it's any abscesses, they can drain the abscesses, or might need to allow the bowel to just rest, allow the colon to just rest and for a little bit, and then they can get just a temporary colostomy, and we'll talk about colostomies a little bit later. And trying to, we don't want that bowel to perforate or anything like that, causing any more severe issues. So an intestinal obstruction. So with an intestinal obstruction, the lumen of the small or large bowel becomes partially or fully blocked. Now, small bowel obstruction is more common, with about 90%, affecting about 90% of patients, and it's usually more serious. If it's left untreated, a complete bowel obstruction in any part of the bowel, whether it be the small or large bowel, can cause death within hours because of shock or vascular collapse or anything like that. Now, bowel obstructions can result from a variety of different things. Obviously, a tumor could block the bowel. Adhesions after you've had surgery. A lot of times after surgery you have some scar tissue. So if you've had repeated surgeries or whatnot and you have continued scar tissue building up, those adhesions could cause that. Volvulus, which we call is twisting of the bowel, and the bowel actually twists. Gallstones, hernias, which we'll talk about as well. All these can cause what we call a mechanical obstruction. A mechanical obstruction, something's, actually physically blocking it. Or then you have non-mechanical reasons for bowel obstruction. So paralytic ileus. Paralytic ileus means the bowel contents, so the stool, is not moving through. And so, you get an intestinal obstruction from that. And that can occur, paralytic ileus can occur a lot of times after surgery. It can result, or if you've got some kind of infection or something like that. It also can happen if you've had thrombosis or embolism or something. Okay, so an intestinal obstruction. An intestinal obstruction occurs when the lumen of the small or large bowel becomes partially or fully blocked. And it's a lot more common. Small bowel obstructions are actually a lot more common because they affect about 90% of patients. And it's usually more serious as well. But if it's not treated, a complete obstruction in any part, whether it's the small or large bowel, can cause death within hours because of shock or some type of vascular collapse or whatnot. So now obstructions can occur from a variety of different reasons. You have mechanical obstructions that can be the result of adhesion. So maybe after surgery, after you've had surgery, you may have adhesions that develop, or scar tissue, that develops. And if you've had several surgeries and, scar tissue build up over time, that can cause blockages. Strangulated hernias. So we'll talk about strangulated hernias here in a little bit as well. But those can cause bowel obstructions. Tumors can block the actual bowel and prevent the movement of bowel, in the intestines. Volvulus. Volvulus is a twisting of the bowel. So when the bowel actually twists, that can cause an obstruction of the bowel. So those are some types of mechanical obstruction. As mechanical as something is physically blocking that bowel, preventing the passage of the intestinal contents from passing. You also have non-mechanical obstructions. Several things can cause non-mechanical obstructions. For instance, electrolyte imbalances, toxicity, all these things can prevent the bowel from moving or passing through. Neurogenic abnormalities, as we talked about with some of our neurologic disorders, actually, stop the passing of the intestinal contents from moving through. Thrombosis or embolism can also, cause or prevent. So when you have that obstruction in the blood supply to part or all of the obstructed section, when that's cut off. So all these things can, increase a person or put a person at risk for an intestinal obstruction. Okay, so signs and symptoms of intestinal obstruction may likely depend on where in the bowel the obstruction is occurring. So if we're talking about small bowel obstruction, so that would be high up in the intestines. You want to assess for a colicky pain, so the pain comes and goes. Nausea and vomiting, constipation might all be signs of intestinal constipation. You're going to auscultate for like a high-pitched, loud, musical bowel sounds, and it might rush. So occasionally it might be loud enough that you could hear it even without a stethoscope. You want to palpate for abdominal tenderness when you have with moderate distension. Rebound tenderness may also occur when the obstruction has caused strangulation. So rebound tenderness would be like when I push down on the abdomen and then I let go, and then they have pain when you let go. Also, when we're talking about depending on high up in the intestines, it can cause some respiratory difficulty too if it's pressing up against the diaphragm. You could have some respiratory difficulties as well. When we're talking about large bowel obstructions, so obstructions in the colon, you want to assess for constipation in the first few days. Also, they might have some colicky abdominal pain as well. Abdominal distension, vomiting, usually late, so they might have some nausea, but usually the vomiting doesn't occur till later on in the process. Now, if the person has a complete bowel obstruction, you actually might notice a fecal odor or actual fecal material in the emesis. So when they vomit, they might have fecal matter in the emesis as well, or there may be a fecal odor because they're not able to release the stool anywhere, so it has to come out somewhere. So if there's a complete obstruction, you might notice that as well. Okay, treatment for abdominal obstructions. When we're talking about preoperative treatment, you might need some fluid and electrolyte imbalances if the nausea has been, excessive to the extent where they have some fluid and electrolyte imbalances. You might need to decompress the bowel to relieve vomiting and distension. So they might put a NG tube in to decompress and remove any intestinal contents or mucus or gas or anything from the intestinal area wherever the blockage is. They might have to have surgery. So if it was a volvulus, which remember we said was a twisted bowel, they might have to have that area of the bowel untwisted. If it's adhesions, they might have to have surgeries to break up those adhesions. Go in there and break up those adhesions so that the bowel can pass. If it's a hernia that's causing the blockage, then surgery to repair that hernia. And then if it's a tumor, they might have to have a colectomy where they remove a portion of the bowel as well. So, all those might be, things that might need to occur depending on how bad the obstruction is. So, nursing management for an intestinal obstruction, you want to keep them probably in a Fowler's position. That's going to help, relieve pressure off that area and help with removing gas or intestinal contents or things like that when you're in that normal sitting pattern for when you would typically, defecate. Monitoring fluid and electrolytes, especially if they've been vomiting a lot, making sure you monitor that, as well as INOs if they are vomiting a lot or whatnot. If they have an intestinal obstruction, you want to have them NPO, because if nothing can pass through, you don't want to just keep putting food and things in the GI tract and nothing can pass through. So you want them NPO till you can get this resolved. You want to measure the abdominal girth every 2 to 4 hours, because you want to ensure that the abdomen is not getting larger and that they're, having an increase of intestinal contents continuing to build up, and of course managing the person's pain level. If it's continuing to get worse, then that may mean that obstruction is getting worse, and they might need to have surgery. All right, so let's talk about an abdominal and an inguinal hernia. So previously we talked about a hiatal hernia, which was up higher when you had the weakened area in the diaphragm. So when we're talking about an abdominal or inguinal hernia, that's a weakened area in the muscle wall of the abdomen. And so that allows the intestine to break through that weakened or defected area. And so a few different things can be the cause of this. Like if you do a lot of straining to, heavy lifting, that can cause a hernia. Having a chronic cough, or straining when you're trying to avoid or pass stool. Those things can cause abdominal or inguinal hernia. And ascites, so ascites is when you have an accumulation of fluid in the peritoneal cavity. Those things can all cause abdominal or inguinal hernia. So you have a couple different types of hernias when we're talking about abdominal and inguinal. You can have reducible or irreducible. So when we talk about a reducible, that's just what it means, reducible. So if I were to lay down or whatnot, then the hernia can actually be pushed back in. It'll go back in place, pretty easily, or whatnot. Irreducible, you can't push it back in. You can't push it back in. So it could be called irreducible or incarcerated. And that means you cannot push it back in. And so what happens, this is actually what we were talking about. I believe we mentioned it before, a strangulated hernia. So a strangulated hernia, if I have that area or that abdominal wall is strangulating that part of the intestines, and so and it's preventing it from being able to be pushed back in. So if it's so tightly wedged in that abdominal wall, then it's going to cause, so that's where you get, when we talked about that um, abdominal blockage, when you had a complete bowel blockage. And so that's when we talked about that. That's how you can get that. So the other thing too, it will cut off your blood supply to that area of the intestines. And so when you think about it, if your blood supply is being cut off to a particular area, the blood carries oxygen and nutrients. So if that particular area of the intestines is not getting oxygen, what's it going to do? It's going to die. So we got to get this corrected right away, because like I said, the blood supply to that area will be cut off, and that area of the intestines can die. So you might see it called strangulated or incarcerated. So signs and symptoms would just be, to determine if it will be based on whether or not the hernia is reducible or irreducible. If the hernia is reducible, then you'd have that abnormal pouching or swelling of the abdominal wall or groin wherever the hernia is. And then, like I said, when you lie down, it would just disappear. But if you, get up and do something, or, lift something heavy or cough or something, then it might, push back through that weakened area. Now, if the hernia is incarcerated or what we call strangulated, then of course they're going to have some pain to that area as well. And so if it's causing the intestinal contents to be blocked, and you've got a bowel blockage, then all those things we talked about with intestinal obstruction can occur. So you can get all those things we talked about when we talked about intestinal obstruction. And then, like I said, if it's cutting off the blood supply, it's an emergency. We got to get that taken care of right away, because if it's cutting off the blood supply and that area of the bowel is not getting blood, it's not getting the oxygen and nutrients it needs, and then it's going to die. That area of the bowel will die. So treatment and nursing management for patients with abdominal or inguinal hernia, you might need to do a surgery. Maybe they need a herniorrhaphy, which is where they actually suture the defect in that muscle wall, so preventing the intestines from being able to protrude by suturing that defect there. There's also hernioplasty, where they actually sew a synthetic material over the defect to reinforce the wall so that the intestine can't protrude through that area of the intestines. So after the person has this hernia repair, of course you're going to have to do things to manage and prevent their manage and control their pain, and educating them on things that they need to do to prevent the hernia from occurring again. So you don't want them doing any heavy lifting or pushing or pulling. You don't want them straining, so they need to make sure they do all those things we talked about to prevent constipation and things like that. So anything that would be increasing that intra-abdominal pressure, you want to prevent those things. If they do have to cough or sneeze, then they can use a pillow or something to support that site, or maybe they have a binder, abdominal binder or something they can use to put over the site to support A lot of times, they'll just have them put a pillow there or whatever to support that site after a person has had abdominal surgery. This picture is actually in your book, and it kind of just shows you what an inguinal hernia might look like, or then you got that umbilical hernia up higher or whatnot. So it just kind of shows you what the hernia would look like, but the picture is in your book as well. Okay, bowel ischemia. Anytime you see that word ischemia, you know that there's a lack of blood supply to whatever area you're talking about. In this particular situation, of course, we're talking about the bowel, so we're talking about lack of blood flow to a particular area of the bowel. And so remember, we said if there is a lack of blood supply to a particular area, then that particular area is not going to get oxygen. So if that area is not getting oxygen that it needs, then that area will die. So bowel ischemia, this can be acute or chronic. So your signs and symptoms, you might see sudden onset of severe abdominal pain. They might also have nausea and vomiting, diarrhea as well. Abdomen might be tender when you palpate it. Bowel sounds might be minimal or absent as well. Now remember, before we're documenting absent bowel sounds, we want to listen in each quadrant for at least 5 minutes before we say bowel sounds are absent. But it makes sense when you think about bowel sounds being minimal or absent. If you're not getting blood flow to that area, then the bowel sounds will be diminished. But just like I said, make sure you're listening for at least 5 minutes each quadrant before you say absence, and you might have some elevated white blood cells. And so treatment and nursing management for bowel ischemia, you want that person to be NPO. And they probably will have a NG tube inserted to try to relieve any distension that they might have. NPO because you don't want to fill the bowel up with food and things like that, and it's not flowing through properly or whatnot. They might need IV hydration as well, and so you're going to monitor their fluid, their INOs, and then they might need a catheter as well. Now, if the situation was caused by a thrombus or embolus, then they might need, some thrombolytic therapy, so maybe heparin or something like that to help, resolve that issue. And then, like I said, if the issue is not resolved, then that area of the bowel will die. And so if it dies and becomes necrotic, then the person might need to have surgery to remove that area of the bowel or something. So inflammatory bowel disease, it's a term that encompasses several recurrent inflammatory gastrointestinal diseases, and the cause is unknown. Ulcerative colitis primarily affects the rectum. So when we're talking about inflammatory bowel disease, that encompasses two disorders of the GI tract, so ulcerative colitis and Crohn's disease. Now, ulcerative colitis primarily affects the rectum and the left colon, and Crohn's disease, it can affect any part of the GI tract, but the disease most commonly occurs in the terminal ileum and the colon. Ulcerative colitis has a higher incident rate than or occurs, typically tends to occur more frequently. Okay, so for as ulcerative colitis progresses, the the colon itself starts to undergo changes. Initially, the colon's mucosal surface becomes dark and red and velvety, and then you start to get abscesses that form and turn into ulcers. You get necrosis of the mucosa. As the abscesses start to heal, you get scarring, and a thickening may appear on the inner muscle layer of the intestine. And then as the granulation tissue replaces the muscle layer, the colon starts to narrow and shorten, and so starts to lose its characteristics or whatnot. So you might have recurrent bloody diarrhea, and then symptom-free remissions are characteristic of ulcerative colitis. The stool typically contains pus and mucus, so you want to assess your patients for some of the different signs and symptoms you might see. Abdominal pain, they might have irritability, they might have weight loss, they might have weakness or anorexia, so not wanting to eat, so they're not going to be eating, so that's why you get the weight loss and maybe weakness. They might have a fever as well. They might have some constipation, especially in your older patients. Now when we're talking about Crohn's disease, it's kind of going to depend on the location and the extent of the inflammation. At first it might be kind of mild or whatnot. In the acute phase of the disease, you want to look for right lower abdominal quadrant pain or cramping or tenderness. They might have flatulence, nausea, fever, diarrhea, and bleeding. In the chronic diseases with Crohn's disease, you want to look for diarrhea, 4 to 6 stools a day, right lower quadrant pain, mucus in the stools, weight loss, possible weakness, as well. For these individuals, they'll be have malaise and fatigue as well. So obviously, if these patients are having diarrhea, we're gonna do some anti-diarrheals or something like that. If they're having abdominal cramps, something to help with that as well. Because they'll have inflammation, you want to give some type of anti-inflammatory. So you want low fat, low fiber foods, but make sure they're high in protein and high in calories, because they will be at risk for weight loss. So make sure their diet's high in protein and high in calories, but low fat, low fiber. Small meals, small frequent meals, so they're not getting overwhelmed with food trying to be digested through the intestines or whatnot. Small frequent meals. Avoid lactose, corticosteroids to help with that inflammation. If they're having an attack, and of course, if they're having diarrhea and whatnot, they may need some fluid replacement. They may need a blood transfusion if they are having any type anemia, or if they're having anemia or whatnot. And depending on the severity of it or what's going on, they might need to have surgery and remove a portion of that bowel. They might need to have an ileostomy, and we'll talk about that here shortly as well, to allow that bowel to rest for a bit. So nursing management for a patient with inflammatory bowel disease. You're going to do a complete health assessment. for this patient. You want to provide rest and nutrition for the patient. The nurse should discuss the patient's feelings about the disease and any lifestyle changes that the disease imposes. The nurse should also check the patients frequently and be attentive to the patient's concerns, because this could be, overwhelming and emotionally, stressful for the patient. So check on them, be attentive to them. Because the patient's diet is very important, the nurse should work with the dietitian to try to increase the patient's calorie count and record the patient's caloric intake, as well as the patient's INOs. You want to keep count of the patient's INOs. The patient may also need a special diet so that there's very little residue in the lower GI after the patient digests and absorbs the foods. May need enteral feedings, may need things like Ensure to ensure that they ensure or boost or something to ensure that they get the nutritional needs that they need. You want to monitor the patient's stools. The nurse should monitor the color, the consistency, the number of stools, and note the information in the patient's medical record as well. Most patients might be placed on medications such as corticosteroids to try to decrease the bowel inflammation. You want to measure their weight daily. As we said, having diarrhea, that could be causing a weight loss, as well as if they're not eating properly. So making sure they're not losing weight. Auscultate the bowel sounds. Make sure bowel sounds are active. You do not, now if your patient, remember, if before we document absent bowel sounds, we want to listen in each quadrant for at least 5 minutes before we document bowel sounds are absent. Also monitor the condition of the perianal skin. It's important to monitor the patient's skin in the perianal area at least every 8 hours. After each bowel movement, the nurse should encourage the patient to clean the area with warm water and maybe apply a protective layer of cream or ointment to the irritated skin. And of course, if the patient is not able to maintain skin care, then the nurse should offer assistance as needed. You want to make sure you check for signs of internal bleeding. So is the patient having bloody stools? Check for occult blood daily. That's blood that you can't necessarily see, visibly with the eye. So you might have to go at the stool. Checking the patient's hemoglobin and hematocrit. A low hemoglobin and hematocrit could be indicative of bleeding as well. And then monitoring electrolyte imbalances as well. So the appendix is a small finger-like projection that's attached to the cecum of the which is in the intestines. And so appendicitis is inflammation of the appendix. And so a lot of several things can cause, with it being right there in the intestines, it can get infected easily. And so because you got bacteria that's passing through the intestinal tract, so it can get infected easily. Obstruction of the opening of the appendix can trap fecal matter in the appendix as well, and that can cause inflammation of the appendix. So this is a common major surgical emergency. It is an emergency that needs to be dealt with. Initially, when we're talking about signs and symptoms, initially the patient may manifest signs and symptoms of, they might have abdominal pain, generalized or localized in the right upper abdomen, and eventually the pain will localize in the right lower abdomen. So right lower abdominal pain, which is McBurney's point. You may hear McBurney's point. They may have anorexia, nausea, vomiting, abdominal rigidity. They also may have retractive respirations, increasingly severe abdominal spasms. They might have rebound tenderness on the opposite side of the abdomen. So rebound tenderness is when you press in the abdomen and you release, and then you have that pain. When you release, you'll have the pain. And so rebound tenderness can suggest peritoneal inflammation as well. Now later, as this continues to progress, they may have constipation, although diarrhea is also possible. They might have a fever somewhere between 99 degrees Fahrenheit to 102 degrees Fahrenheit. They may have tachycardia, increased white cell count. The muscle guarding, because guarding is, when they're guarding and trying to keep you from touching the abdominal area. Now, if the abdominal pain suddenly stops, that could be an indication of perforation. So that it's perforated, so meaning that it's burst. So like I said, this is a medical emergency, and it needs to be taken care of right away. So an appendectomy is the only effective treatment for appendicitis. Now, if peritonitis develops, and we'll talk about that in a moment, but if it develops, then treatment would mean they need GI intubation, replacement of fluid and electrolytes, and antibiotics, administration of antibiotics. Now, the patient can be observed for 6 to 10 hours if no immediate surgery is needed. But if infection is widespread, then immediate surgical intervention is needed. So for suspected appendicitis, to prepare for an appendectomy, you want to administer IV fluids to prevent dehydration. You never want to administer cathartics or enemas. Cathartics are medications that accelerate defecation, because these things can cause the appendix to rupture. So you never want to administer those things. The patient should have nothing by mouth, so they should be NPO. You placing the patient in a Fowler's position might be good to help reduce pain. The Fowler's position might also be helpful postoperatively. You never want to apply heat to the lower right abdomen or perform any palpation to that area either, because these things can also cause the appendix to rupture. After the surgery, you want to monitor the patient's vital signs, monitor their INOs, give analgesics as ordered for pain. You want to document bowel sounds when they pass flatus, which is gas, or you want to document any bowel movements. You want to watch closely for possible surgical complications. So continued pain and fever might be a signal of an abscess. So you want to, monitor for that. If an abscess or peritonitis develops, Incision and drainage may be necessary. So you want to frequently assess the dressing for any wound drainage. You want to just continue to monitor their pain, take their vital signs, check the abdomen for rigidity, because like I said, that could also be an indicator of a ruptured appendix. And then also prior to the surgery, obtaining a diet history for the past 24 to 48 hours to make sure that we're not dealing with food poisoning. And then the date and character of their last bowel movement. An ultrasound of the abdomen and the pelvis can help diagnose a non-perforated appendix. So, and a CT scan can help identify if there's an abscess as well. So, peritonitis is an acute or chronic inflammation, and it may extend throughout the peritoneum. And the peritoneum is the membrane that lines the abdominal cavity and covers the visceral organs. Or it could be localized. Now, peritonitis commonly reduces intestinal motility and causes intestinal distension with gas. So, decreases the movement in the intestines. Mortality is about 10%, and death usually is the result of sepsis or progressive organ failure. Now, peritonitis results from maybe like a bacterial infection due to a ruptured appendix or perforated bowel or a strangulated obstruction in the abdominal area, some type of abdominal neoplasm or a stab wound or something like that. It can also occur from chemical inflammation that occurs with a ruptured fallopian tubes or bladder, ruptured fallopian tubes or bladder, a perforated gastric ulcer of some sort, diverticulitis that perforated, and like I said, some type of trauma of the colon or the spleen or the liver or something like that. And also patients receiving peritoneal dialysis could be at risk for peritonitis as well, because with the risk of the pathogens entering the abdominal cavity when they through their dialysis catheter. So that puts them at risk for peritonitis as well. So any of these organs rupturing in the abdominal area puts a patient at risk for peritonitis. Now, if peritonitis is not treated right away, it can be fatal. The main symptom is like a sudden severe abdominal pain that intensifies and localizes in the area of the underlying disorder. So if the thing that caused the peritonitis, say it was the ruptured appendix, so in that area where the pain would tend to intensify. So wherever, whatever organ that was that perforated or whatnot or caused the issue. The patient might have weakness or pallor, excessive sweating, chills, cold skin, decreased intestinal motility, like I said before, abdominal distension, shallow breathing. They might have shallow breathing. maybe tachycardia. They might have a fever. Fever might be like 103 degrees Fahrenheit or higher, so pretty high fever. Um, Nausea, vomiting. So for peritonitis, you're going to treat this patient with, they're going to need massive antibiotic therapy to, you want to try to stop the infection. Our goal is to stop the infection, restore the intestinal motility, and replace fluid and electrolytes. So they're going to need IV antibiotics, they're going to need IV fluid and electrolytes, and gastric or intestinal decompression to relieve the distension. So that's when we had talked about before, the GI intubation. So to decompress and relieve that distension, get that excess fluid and gas out of that abdominal area. And then whatever the ruptured organ, you're going to need some type of surgical procedure to repair that organ. So like I said, if it was the appendix that ruptured, then you're going to have an appendectomy to remove that. So whatever the organ is the issue, or the ruptured organ, you need surgery to repair that. So for nursing management, you're going to assess these patients frequently, obviously. And so, like I said, Semi-Fowler's position can help with comfort and pain, because think about if we got all this fluid or whatever is building up in the abdominal area, it'll be pressing on the diaphragm and pressing up and making it difficult to breathe. So positioning in the patient in a Semi-Fowler's position can help relieve the respiratory issues and facilitate breathing. Checking vital signs every 15 minutes when the patient is in that critical stage. Pain management, obviously. You want to auscultate those bowel sounds. Remember, we said before you document absent bowel sounds, you want to listen in each quadrant for at least 5 minutes in each quadrant before we say absent bowel sounds. Record if the person is having flatulence, which is gas, or feces, which is bowel movements. Patient's going to have a high fever, so we need to be monitoring that fever and giving meds to try to bring that down. And the patient, because of this high fever, the patient's going to potentially be delirious and disoriented. So watching and making sure they don't hurt themselves because of this. Turn them very gently. They're going to be in a lot of pain, and mouth care, because this high fever can cause dry mouth and whatnot. And then also, like I said, they'll have that GI intubation, so they'll have the gastric tube in that's trying to decompress the abdominal area. So mouth care because of that as well. Okay, so sometimes depending on what's going on, we might need to perform surgery. We'll perform an ostomy on our patients. An ostomy can be temporary, or it can be permanent. Sometimes we need to form a temporary ostomy just to allow the bowel to rest for a period of time. And so a bowel surgery with ostomy is when the surgeon removes the diseased colon and rectal segments and creates a stoma on the outer abdominal wall, and that allows for fecal elimination through the outer wall of the abdomen. So you might need ostomy for a variety of reasons. Like I said, sometimes with your Crohn's patients, you need to allow that colon to just rest, for a bit, or sometimes it could be permanent. If you have cancer, colon cancer, you might have to have an ostomy or whatnot. But ostomy can be placed in different areas of the bowel. So you can have a colostomy, and a colostomy is when there's an incision made in the colon. So you got different sections of the colon that you can have a colostomy. So the ascending colon is the coming up the right side of the abdomen is the ascending colon, and then the transverse colon would be horizontal coming across the top, and then the descending colon would be going down the left side of the colon, because that's the natural that's the pattern of the bowel. So you got the ascending colon, transverse colon, descending colon, then the sigmoid, and then out the rectum. So if the colonoscopy is placed in the ascending colon, the stool has not had an opportunity to go through the entire colon to be, and so then, the fluid has not been absorbed because the stool has not gone through the colon. So if the colostomy is placed in the ascending colon, then that stool is going to be pretty watery because the stool has not had a chance to go through the colon as of yet. If the colostomy is placed in the transverse colon, it's gone through the colon a little bit, but not fully. So the stool will start to get a little mushy and soft or whatnot. If the colostomy is placed in the descending colon, then it's going to be formed because it's had a chance to go through the colon, the whole colon, and so the stool is going to be more formed if it's in the descending colon. Usually, ostomies that are placed in the ascending or transverse will be probably more temporary, more of your temporary ostomies, and your ones placed in the descending colon would be more of your permanent type colonoscopies. Now, individuals can shower with these ostomies. It's just a matter of wherever it is, the stool will be running out constantly or not. Now you can also have an ostomy placed in the ileum. So the ileum being, in the small intestines. And so the stool definitely has not gone through the colon at this point. So if you have an ileostomy, so if the ostomy is placed in the ileum, it's called an ileostomy. So if you have an ileostomy, the stool is going to be very liquidy, and it's going to contain digestive enzymes. And so you got to practice good skin care for these patients, because it's going to be very irritating to the skin, because stool will be constantly running out, and it'll be liquidy and have a lot of digestive enzymes. A lot of times they'll do this ileostomy for patients with ulcerative colitis or Crohn's disease, or even some types of malignancies and polyps and things like that. Okay, so you want to make sure you provide good skin care for your stoma and the skin, where the ostomy is, because with stool getting on the skin, it can irritate the skin and cause skin breakdown, and so we don't want that. So we want to make sure we provide good care of our stoma and the skin around. First of all, we want to make sure we inspect that stoma. It should be a nice pink or a deep red color. That will indicate that there's good blood flow going to that area. Now, if the stoma is black or dark purple or something like that, then we need to report that because there's not adequate blood supply getting to that stoma. Initially, after the stoma has been placed, you might see some slight bleeding, but nothing more than that. You need to report that. Check the stool, make sure there's no, this is still coming from the intestine, so we shouldn't have blood in the stool or anything like that. That still could be indicative, bleeding in the intestines, so it's still coming from the intestines. Like I said, assessing the skin, making sure we, keeping that area nice and clean, making sure the stoma's not swollen or anything like that. Now, the wafers that are placed around the stoma you should cut it like 1/8 inch larger than the stoma itself. You don't want it too tight where it's cutting off the blood supply to the stoma, but you don't want it too loose either, that allows stool to get around on the skin. So about 1/8 inch larger than the stoma is how large you'll cut that wafer to place on the abdomen when you're changing that wafer. Typically, those wafers are changed weekly. The bag itself, or the pouch itself, for ileostomy, because that one's going to be draining a lot of liquidy fluid. So once that bag is half full, you want to empty that bag, because if it gets too full, then it'll start to pull the wafer away from the skin. And so then if you're pulling the wafer away from the skin, then you're going to start to get stool on the skin, and then you're at risk for skin breakdown and all that. You want to monitor, make sure they're not dehydrated, especially if they have an ileostomy, or if it's in the ascending colon, or where they got a lot of liquidy stool. So watch them for dehydration and monitor their INOs as well. Usually right 24 hours after they have the ostomy placed, they may be on antibiotics as well. Okay, peristomal skincare. Peristomal means the area, the skin that's surrounding the actual stoma. So, like I said, you want to make sure you provide good care to that skin surrounding the area, because you don't want it to break down. If you have stool that's seeping on that skin, that can be irritating to the skin. So, when you're changing that stoma, not changing the stoma, when you're changing the wafer or the entire device, you want to wash the peristomal area with some soap and water and dry it real good before you apply the wafer. And like I said, they can actually take a shower if you take that wafer off, they can get in the shower with it. It'll just be a matter of the location of the actual stoma. Is stool going to be constantly coming out of it or not? Remember, we said if it's in the if it's an ileostomy, the stool's going to be real watery, and then if it's in the ascending colon, it's going to be runny as well. So you'll probably have stool, continuously coming out, versus if it were in the descending colon, you could probably get through a whole shower and nothing comes out. But you want to make sure you're cleaning that area around the stoma very well. When you put the when you attach the wafer to the skin, you want to make sure you have a good seal around the skin. And they have a lot of different things you can use to help get a good seal. You can use there's a skin barrier paste that you can apply. There's also, it looks like an alcohol wipe, but it's not. It's an adhesive wipe, and it helps that wafer to stick better to the skin. There's also a spray that you can use. So there's a few different things you can use to try to help that help that wafer to stick to the skin a little bit better, because you want to make sure you get a real good seal, because you don't want stool leaking out onto the skin and sitting on the skin and irritating the skin. Like I said, the whole device is changed typically weekly. Some facilities they might change it every twice a week. In some facilities, depending on what their policy is. So about 1 to 2 times a week, unless, of course, it's visibly soiled or coming off or something like that, then you might need to change it. Now, just think about these people, especially for a patient with a new stoma. They might have some psychosocial issues, altered body image. So you want to, tend to their psychosocial needs as well. Try to get them involved in activities. A lot of times I've had patients that are paranoid, that there's a smell, and so they don't want to go out in public, because they're thinking, oh, it's gonna, smell or whatnot. And so dealing with, those psychosocial issues, it could be something for that patient. There's also actually, if there is an odor, or, they have difficulty, they've been eating a lot of foods that cause gas or whatnot, there's like uh, a deodorant. It's a drop. It's a deodorizing drop. You just put a couple drops in the bag to help with that odor for the patient. Maybe you get the gas out or empty the bag before they go out, so that they don't have to worry about that having a smell or odor or whatnot when they go out. So it can be a little challenging in that sense as well. So you got to tend to those needs as well. All right, so teaching for your patient with a ostomy, you want to teach them to eat 6 small meals a day rather than 3 large meals, and teach them to chew their food slowly. So you want them to have maybe a soft diet, especially like 6 weeks after just getting ostomy, because you don't want things to block the ostomy or block the stoma. So avoiding foods like dried fruits and corn and popcorn and nuts and sunflower seeds, sausages, thick meats, things that could potentially block that ostomy. So you want to teach them maybe cook their foods thoroughly instead of eating raw fruits and vegetables and things like that, because those type things can actually clog the ostomy. Um, things like cabbage and whatnot, those can, cause gas and things like that. So maybe, teaching your patients about what foods they should and should not eat, especially that first 6 weeks after getting it. You want to, be very careful. Introduce foods gradually, slowly. So, one at a time, so that they can see how their system handles that particular food. Patients with the ileostomy, so remember we said the ileostomy, so that's the last part of the small intestines. So if I have an ileostomy, it has not, whatever I'm taking, food, medication, or whatever, has not had time to be absorbed in the intestines. So you should not, patients with ileostomies, you should not give them time release or enteric coated tablets or capsules, because these medications have not had enough time to get absorbed in the system before it's released. And so don't give them those type things. Make sure your patient is getting adequate fluid, because you don't want them to get dehydrated. So encouraging them to drink plenty of fluids, so that they don't get dehydrated. All right, so hemorrhoids. Hemorrhoids are varicosities um, of the veins in the rectum. So varicosity means abnormally dilated veins. So the veins are enlarged. Now hemorrhoids can be internal or they can be external. So as the nurse, if they were external, you would probably, you may be able to see them. Versus if they were internal, you might not be able to see them. A lot of different things can cause hemorrhoids. So things that cause straining or pressure in the rectal area. So like constipation. So when you're straining because you're constipated, that can cause hemorrhoids. Obesity, you're putting a lot of pressure in that area, can cause hemorrhoids. Prolonged sitting or standing, that can also cause hemorrhoids. Pregnancy, an enlarged prostate, a uterine fibroid. If it's large enough and it's putting a lot of pressure in that area, then that can cause hemorrhoids as well, or rectal tumors. Now, chronic liver disease with portal hypertension. So, portal hypertension is when you have an increase in pressure in the portal vein, and the portal vein is what carries blood from the digestive organs to the liver. So all these things can put enough pressure in the rectum area and cause these dilated veins or varicosities of the veins. Okay, so hemorrhoids, you might have some pain and itching in the rectal area with the hemorrhoids, and then you might have some bleeding with your bowel movement, especially if it's an internal hemorrhoid. So the bleeding will usually be bright red, um, to slightly a little bit darker. The higher up the bleed is, so the higher up the intestines the bleed is, the more dark it's going to be. So if the bleeding is coming from somewhere higher up, it's going to get really dark. The blood in the stools will be really dark. You'll be able, you can tell the difference between hemorrhoidal bleeding versus, something that's higher up in the intestines. So bleeding, especially if it's internally, maybe not so much if they're externally, but you'll definitely be able to see them, as I said, if they're, as the nurse, if they are, external. So when we talk about treatment for our hemorrhoids, you got a lot of different options. Sometimes, people might use cyst baths. If it's constipation, obviously you want to relieve that constipation so that you're not straining and continuing to push down or bear down on the hemorrhoids. Sometimes, heat or cold might be helpful. There's a lot of different ointments that you can use that have a local anesthetic that can help, with pain. Um, you know, uh, uh, Hydrocortisone ointments and suppositories are also effective in helping to decrease the inflammation, decrease the hemorrhoid itself. You want to educate your patient that after they have a bowel movement, they want to wash the area with some warm water, because you don't want, stool possibly sitting in that area for an extended period of time, which can, of course, lead to infection. So after they have a bowel movement, wash, that area with some warm water. There's also some wipes that you can use. They have some hemorrhoidal wipes that you can use to help make sure you clean the stool off, effectively. Tell them don't use things with alcohol in them. You don't want to wipe with alcohol-based products. And if need be, if these things, don't um, help to relieve the hemorrhoids by themselves, you might have to take it a little bit further. They have cryotherapy where they can freeze the hemorrhoids, or they have photocoagulation where they actually burn the hemorrhoids. A hemorrhoidectomy is a surgery to remove the hemorrhoids themselves. or rubber band ligation. So now rubber band ligation is where they wrap the hemorrhoid tight and cut off the blood supply. So just think about what happens when we've talked about anything where we've cut off the blood supply to a particular area. What's going to happen? You're going to lose all the oxygen and nutrients to that area, and then that area um, will just die off or whatever. So that's something else that they can do if you can't relieve your hemorrhoids by some of these other non-invasive procedures.